Hey guys, welcome back to the FOAMfrat video podcast. I guess I call it a vodcast. So Sam and I were talking the other day about pulmonary embolism signs and symptoms and some of the really weird ones that we've heard. And, I'd heard we had this patient who had a pulmonary embolism and they were purple from the nipple line up. And I remember thinking that doesn't make any sense in my head. And so we started to dig into the literature and look at the sensitivity and specificity of pulmonary embolism signs and symptoms. And we came across some really cool things.
Yeah, and the literature was a little bit difficult to comb through as well because we were going back and forth with a bunch of different websites because I'd be look at the sensitivity and specificity of this, and then you'd send me something back and it'd be totally different. And I'm like, well, what the heck is going on? So it's difficult, and I guess this goes for any disease process because when you're looking for how sensitive, how specific is this, if they run a case series of these types of patients, how many of those patients actually exhibited this sign or symptom? With pulmonary embolisms, you got to be a little bit careful because there's massive pulmonary embolisms, submassive pulmonary embolisms, and then there's what they usually call non-massive, or they just call them low risk. And so if you group all those together, some of the more serious symptoms or signs that the patient would present with won't be there. And so if you think that the patient, if you look at only patients that have massive pulmonary embolisms and they present with, the hypotension, the right ventricular dysfunction and stuff like that, those signs and symptoms that go along with that right heart dysfunction, they're obviously going to be more prevalent than somebody with some tiny pulmonary embolism. So if you mix those two together, the average is really low, but it's lopsided for the sicker patients.
Yeah, that's a really good point. And I think maybe we could start off by defining a couple of things. So let's define massive versus submassive. What's the difference between the two? Is it the size of the clot?
It's the size of the clot. So, but it's really difficult to measure that, right? And so, when you think about massive, you're thinking, okay, it must be huge, right? And so the way that we basically look at that indirectly. So if the patient has hypotension, and all the literature that I looked at defined hypotension as a systolic blood pressure of less than 90. But there is some literature that'll go and say if the pulmonary embolism is half the size of the pulmonary trunk, which I don't even know exactly how. I don't know if maybe people will be looking at saddle emboli or something. I don't know exactly how you do that, but usually it's by hypotension. So that's the massive ones. Just generally, I guess from here on out in the podcast, when we say massive, we mean somebody presenting with cardiovascular compromise due to the size of this clot, essentially. And then submassive is going to be no hypotension, but there is evidence of right ventricular dysfunction. And so their blood pressure might be totally normal, but maybe they have some of the signs and symptoms that go along with a pulmonary embolism. And then the ones that are even below that, so non-massive, so they don't even meet the criteria of those two, those ones are going to be non-massive, or they might call them low risk pulmonary embolisms. And they really vague symptoms, no hypotension. It hasn't really affected the right side of the heart. Might be really vague symptoms that you're not quite sure what's going on with that patient. And they are low risk.
Yeah, I think of it like, the pulmonary artery leaving, the right ventricle fires up and it's shooting blood into that pulmonary artery, and then it branches off, and so a huge clot burden and something that would be, I would think of a massive pulmonary embolism would take up like you said, a pretty significant portion of that, and that would mean that you have more things like regurgitation back into the right ventricle from the pulmonic valve. You're going to have higher RV pressures, and that's probably where that akinesis of the free right ventricular wall, like you see in McConnell's sign, comes from. And then so submassive, really just if I were to break it down in my head, I think of it just doesn't have the degree of hypotension or any hypotension, right?
Yeah, not the degree of hypotension, but there might the free wall might still be functioning okay. The septum probably isn't forming that D sign that you would see on ultrasound. It's not really, because once that right ventricle gets so big, that's when it starts impinging on the left ventricular function. That's when we're going to start to see the systemic issues with that blood pressure. So that's why in those submassive ones, you can have right ventricular dysfunction, and you might even, see some, I don't know, obviously shortness of breath is really common, but tachycardia starting to compensate for it. Maybe even some of the ECG signs that we'll talk about might start to become present, but it's not until that septum is like really coming into that left ventricle when it really turns into that obstructive form of shock at that point, and the left ventricle is just getting squished by the right, and then obviously preload problem, everything backs up into the lungs, you get the pulmonary edema, and then crappy cardiac output, and then the whole thing just spirals down.
Gotcha. All right. So let's now define sensitivity and specificity, because I think that those two can get a little bit confusing. And the way I think about it, and then you probably have an example of how you make sense in your brain, but I did a video for the refresher course on ST elevation and trying to identify MIs. And I said, what does a criminal look like? And if you were to go out and say, all right, I'm going to look for the guy that looks like a burglar, you'd be very specific. If you see that, you're pretty sure that that's a burglar, but there's a lot of people that could still be criminals that you will miss because you're trying to look for that one thing. And so sensitivity really opens up the net and catches a lot of things. But specificity says if you see it, this is likely what it is. Do you agree with that definition?
I think we should just go with that for today. I like it.
You don't have an illustration to trump mine?
I don't have an illustration for that. I do teach it in one class, but we go over signs on an ECG, and if it's, how sensitive is it? So basically how often is it going to get picked up? And then if that thing does positively get picked up, the specificity then comes into play and saying like, okay, if it is positive, how sure are we that it is this thing, pretty much?
Cool. All right. So let's get into some of these. So what did you find was the most sensitive and specific when you were doing, because we haven't really talked about this much. So we both went and we scoured the internet on our own side. What did you find was like the most sensitive and specific finding for pulmonary embolism?
So I'm going to go with just looking at sensitivity, because I'm going to be specifically talking about people who have confirmed massive embolisms, because those are going to be the patients that we're going to see in extremis. It's not, maybe somebody would disagree, but I don't feel like it's incredibly important to differentiate those ones that are on the not so sick submassive side, or like the low risk ones. I don't feel like that's terribly important. So I specifically went after literature that looked at the massive embolisms. So this was how sensitive this stuff was for specifically massive embolism. So these patients were, I'm sure they look sick. They had hypotension, right ventricular dysfunction, the whole thing, like sick PE patients. It was a case study or a case series, I guess, of 40 different patients. I link it in the show notes and I break down these stats. And they looked at sinus tachycardia. And this was a case series of, by the way, 40 patients. 17 of them had massive, and then 23 of them had submassive. So in the massive group, sinus tachycardia was present in 88% of patients. So that kind of goes along with standard, like we usually think sinus tachycardia. Okay, that's pretty common. And then there's the S1Q3T3. Do you remember, what did you think the first time you heard S1Q3T3 and you heard it associated with pulmonary embolisms?
And so I actually remember, because I was working at the Port Washington Fire Department, and Joe DeBoer came up and he was like quizzing me, and he was like, hey, do you know what S1Q3T3 is? And I had no clue. Obviously they didn't teach us that in paramedic school, and maybe some places do. And so I looked it up and I'm like, man, like that's cool. I did not know that, there was something that was that specific to pulmonary embolisms that you could see on an ECG. And I thought that, I was like, man, he's a PA, dude's got to be really smart. So this is something I probably should have known. I wrote it down, and then I would like to, I'd like to try to punk other people with it. Hey, did they have S1Q3T3? It sounds smart. It sounds like you know what you're talking about when you say it. but it's kind of garbage.
So it all depends. So that was my impression of it too, is like looking for S1Q3. Well, it depends what the context is. Looking for it as if you're looking for a STEMI on an ECG and ruling in, ruling out. For that, I will agree that it's probably garbage. In these patients, in this patient series, 70% of the patients with massive PEs did have S1Q3T3. So it's not horrible, but here's the thing. So let me throw a couple more things in there, and then we'll talk about just the general process of this. And then the other thing that they listed was repolarization changes in right precordial leads. It says 76%. So basically that's right ventricular strain pattern. When we see the inverted, jacked up, maybe there's a little bit of ST deviation in V1 through V4. Usually you're seeing like these deeply inverted T waves or something like that. Just general right ventricular strain pattern stuff, maybe a little bit of right axis deviation, maybe a little delayed R wave progression, stuff like that. Just generally it looks like this right ventricular strain pattern in V1 through V4. So that was 76. But here's the thing. In these patients, in PE patients, there's nothing special about a pulmonary embolism. All it's doing is because the right side of the heart doesn't know what's going on here, which is what we're trying to look at. All the right side of the heart knows is that it's got a lot of endocardial pressure that's pressing from the inside of that ventricle, and it's pressing on the walls from the inside out. And it's just experiencing a ton of pressure. But there's nothing special about pulmonary embolism that causes that. It could also be really bad bronchospasm. It could be air trapping for another reason. Iatrogenic maybe. It could be a tension pneumothorax. It could be really bad pulmonary artery hypertension for some reason, or any of the other 100 things that cause pulmonary
Cor
hypertension.
pulmonale. I mean, right? We're essentially talking about cor pulmonale.
Yeah. Anything that's causing cor pulmonale, where the right and the upper and lower right side of the heart are pretty much involved. And so, yeah, are these things going to be present? Yeah, but the way I'm now looking at these things after looking at the statistics and how sensitive they are in this particular patient population is essentially that if I see these things, I'm not going to say, oh, the patient has a pulmonary embolism. I'm probably going to ask a question and try to answer it another way and say, okay, this is getting me in the ballpark of probably something's backing up into the right ventricle. I wonder what could be causing that. And on my list of differentials would be pulmonary embolism, but there's probably other things. This should be a patient, if you're seeing these things, probably really sick, probably an extremis, probably hypotensive, and then you're trying to differentiate different causes of shock. And maybe this steers you towards the right side of the heart for some reason, but it's just a long list of differentials, but it does get you in the ballpark. So I don't want to diss it, because I do see the clinical utility in it.
Yeah, no, that makes total sense. And we were talking earlier, when you look at all comers, and if you imagine you're an ER doc and somebody comes in with some very vague symptoms, and you're thinking in the back of your head, this could be a pulmonary embolism, but I'm not really sure. Well, that's where things like the PERC and Wells and stuff, some of those criteria, if you have a really low pretest probability or index of suspicion, and then they don't have any of those symptoms, then you can send them home or discharge them or whatever. You're not going to do things like draw a D dimer right away, and then something that's got a very high sensitivity but low specificity, and then that could skewer your whole clinical picture after that. So it is really important that you have that high index of suspicion, and then your pretest probability goes up way high, and then maybe you see the S1Q3T3, and you're kind of using like that Bayesian thinking where you're just collecting all these data points to point you in one direction. The PE that I am really interested in is the cardiac arrest, where you're trying to decide, does this patient have a pulmonary embolism, and is that like what caused them to go into arrest? And early on, I was like, well, you could just look at the heart. And if you see this big right ventricle, well, then that would probably lead me towards being like, hey, doc, you want to give some intra-arrest TPA and, see if this actually is a pulmonary embolism. And then I learned very quickly that is not indicative of a pulmonary embolism. I mean, it is, but almost everybody who goes into cardiac arrest has their right ventricle just blow up because your cardiac output drops and your blood return, you're bringing blood back to the heart. You're trying to pump it out and it just starts to expand. So you can't really go off of that. And so I'm like, well, what could you go off of? And so when I was looking through the literature, what I kept seeing is looking for a DVT and scanning to see if that patient has a deep vein thrombosis. And what's interesting about that is they added that into the rush exam. And I don't know when it was added, but typically the acronym you use when you're trying to remember all of your views for the rush exam is HI-MAP. So you start off with the heart, the IVC, Morson's pouch, and then you can do the splenorenal recess. And then you have the aorta and then P for pulmonary. And then they added ED at the end. So HI-MAP ED. And the E was looking for an ectopic pregnancy, and then the D was a DVT and looking at the legs. And that is way more sensitive and specific. If you have a patient who's in cardiac arrest, they're probably like, what are you doing scanning their legs? But if you grab that linear probe and you look at the things like the, where the saphenous vein and the common femoral artery common femoral vein come together and start looking through those. Typically what I see is you put it in like a short access to where, you're just looking at the vessel like this, and then you compress down on it. And if you can't compress over the vein, it's likely that is a DVT. Now, I don't have a ton of experience with that, but I think it's something I'm going to start digging into because typically the legs are the area during a code that nobody's near. Everybody's up at the head. So it wouldn't be that hard to go down and look at the femoral vein, look at the saphenous vein, and the popliteal is typically the three that you want to look at and see if you can compress those down. So
Yeah,
I thought that was kind of interesting. And then there's things like, if the patient is not in arrest, there's things like the McConnell sign, which is where you have akinesis of the free wall. So if you look, it almost looks like the apex is like moving by itself like a trampoline and everything else is staying still. And then you have like the D sign where you have the septum starting to go into the left ventricle. Those all those they require the patient to have an intact and native circulatory system. So it's a little bit harder to tell in arrest, but I think that I'm going to start looking in their legs and grab that linear probe and see if I can identify any areas that I can't actually collapse. I looked at some of the other things like a fever, which it's interesting actually because a lot of there's some case studies I was reading quite a bit where sepsis and PE, which, they seem like two separate things, were very hard to differentiate. And it was interesting because patients who have a PE are hypotensive, tachycardic. They can have shortness of breath, and dyspnea, hypoxemia, and they can have a fever too. And it's not always, but they can have a fever. And then you think of patients in sepsis, they have the exact same thing. So you could have a patient that you're like, oh man, this is sepsis. And you don't even realize that they have a pulmonary embolism.
Yeah, you were talking, so I want to round back on a couple of those things because I think there's some really cool points. So
sorry, I got going a little bit on that one.
No. So I want to rewind to that DVT thing real quick and just bring to everybody's attention that I have the Wells criteria pulled up here. That's the very first question on the Wells criteria. So anybody who doesn't know, there's like a Wells criteria and then a simplified Wells, and you just add up these points. There's an MD calc on it. I'm going to link it in the show notes. And you just go through.
I'm pulling it up right now too.
What's that?
I'm pulling it up right now too, just so I can look at it while you're going through it.
Yeah, and so it says clinical signs and symptoms of DVT. That's plus 3 points right off the bat. That's one of two heavily weighted questions. And so the two heaviest weighted questions are clinical signs and symptoms of a DVT. The second one, PE, is number one diagnosis or equally likely. That's another 3 points right there. So it kind of comes into that whole patient picture thing, a little bit of your clinical gestalt. You got to know some stuff about pulmonary embolisms for it to be so high on your diagnostic criteria. And then as well, looking for that DVT. And that was really high. That's on the negative exclusion criteria too, for that PERC thing you're talking about. If the patient has history of DVTs, PEs, you can't even rule them out, because if any one of those questions are yes, then they're automatically ruled in. So that was the first thing I wanted to round back on. The other thing was, I thought, and we found out differently when we were looking into some of this stuff, I thought pulmonary embolism patients presented with clear lung sounds way more frequently than they actually did. And you found out some stuff about cardiac output and diversion of blood flow with rails. Can you talk about that a little?
Yeah, that was really interesting. So if you imagine you're going from the pulmonary artery, and then you have the different segments, and then the subsegmental bronchioles going through. And if you have a clot over here, the majority of that cardiac output is going towards these unobstructed pulmonary branches. And so it can flood that system and actually cause pulmonary edema. And you can get the pulmonary edema. And that's one of the most common chest X-ray findings is pulmonary edema and atelectasis. And I'm assuming the atelectasis is literally just because of that, from the pulmonary edema.
Yeah, I thought that was really cool, because you might think, if you weren't aware of that, like, increased cardiac output. And I suppose there's probably two mechanisms to it as well. It's like this increased cardiac output that's going to areas that are unobstructed. And then as that pressure starts to build up, because that pressure is forcing, hydrostatic pressure is going to force some pulmonary edema into the vasculature. That's going to, it's like almost there's three. So it's obstructed. So it's going to areas that are unobstructed. So it's got less real estate. And then once those areas start to fill up with pulmonary edema, you might start to get some hypoxic vasoconstriction on the other side. And then two, the more it backs up into the right side, the larger that right ventricle gets, starts to impinge on the left, and the left side, on the other side of the septum. And then you just get regular old backup, just like you would get cardiogenic pulmonary edema from left-sided failure. So that was in some of these show notes that I mentioned before. I was trying to find it, and this is indiscriminate. So this is all comers. Rails were present in 18% in this case series. So I'd imagine in the really sick patients, it was much more common. And so I thought that was crazy. If I were to hear that on a pulmonary embolism patient, unless they were in frank heart failure from obstructive shock, I wouldn't immediately think, where is that, or know where is that coming from. I thought that was a really interesting point.
Yeah, I was trying to find it. There was an MCRIT podcast, and I want to say the guy's name was like something Orman Freeman or Orman Friedman. I'd have to look it up. That's why I was trying to see it. But he did a talk on pulmonary embolisms, and he said it's interesting. When somebody's getting like a lung removed, a lobe, they'll actually like clamp off that part of the circulation, and these patients don't go immediately into like right ventricular failure. And so I thought that was interesting, because you think of a pulmonary embolism, it's clotting, and then all of a sudden the RV starts experiencing higher pressures, and it's not doing too well with those higher pressures. And I was like, why doesn't that happen if you were to go in and just like literally clamp it off? And it's a lot because of or a lot of it has to do with the cytokine release and all the inflammatory mediators that start clamping down everything, not just where the actual clot is. And so when we give heparin to a patient who's in a pulmonary embolism, we're not giving it to break down that clot. We're actually giving it to avoid more clots from forming. And I thought it was interesting. I was reading yesterday that every patient who has a DVT will have like subclinical, like maybe asymptomatic pulmonary embolisms, little microemboli that break off and go through, and you never even know that happens. But when it starts to build up and maybe more of that gets broken off, that's when we start seeing the actual symptoms from it. And so that's why they'll do things like put in an IVC filter if they know somebody's got a big one starting to grow in their leg. They'll do things like heparin to avoid it from getting bigger, but you're not giving heparin to dissolve that clot that's in the lungs. You're just giving the heparin to avoid it from getting bigger and from it accumulating on those leading edges and expanding into maybe different generations of or not generations, but different vasculature within the pulmonary arteries. And then the things that I find really interesting now are, because like heparin, okay, we all know that, but like some of the inhaled pulmonary vasodilators that we can give to try to relieve that right ventricular pressure. And I remember Josh Farkas was talking about nebulizing nitroglycerin. And I really like that. And one of our buddies actually does that with their program. And you have more of the details with how they actually do that, but I thought that was really interesting.
Yeah, I got most of the details from that Bleeding Edge series that Farkas did, and they used really concentrated nitroglycerin, if I'm remembering correctly. I want to say that they put 5 milligrams into a small volume nebulizer, which I want to say like, you probably need close to a milligram per milliliter, which is not usual IV nitro concentration. It's usually somewhere between 50 and 200 or 250 mics per milliliter. So their stuff was really concentrated because they're just putting in a regular old small volume nebulizer, and then they're just giving the patient that nebulizer treatment. So maybe they put them on, I don't know, CPAP. If that doesn't work, attach the nebulizer to it. And the cool thing about those pulmonary vasodilators, nitroglycerin, is that it's only going to the areas that are aerated. So it will never cause a VQ mismatch, because if it's aerated, it will vasodilate that area, cause blood flow through it. So you're not doing this indiscriminate, give them sublingual nitro, whatever, or IV nitro, where it's vasodilating everything. Because then if the patient does have hypoxic vasoconstriction somewhere, you're going to reverse that and you could worsen their VQ mismatch. So you want to do this inhaled stuff because it's very targeted therapy. And so I thought that was really cool. Not a lot of literature if there's strong rebound vasoconstriction yet, but there hasn't been any case reports of that. Because, the Flowlan or Inomax or whatever, you stop that stuff and they can rebound vasoconstrict, and then they're like screwed. You cause a huge obstruction going through the lungs. Seems like nitro might be a little easier to manage, but I don't think we fully know yet. I don't think it's one of those things where you have to keep it going like all the time, but it's something that people are looking more into. So as that becomes more common, I think that actually could be really cool.
Yeah, I agree. I'm really interested. I don't really see a downside of it. I think that even in a patient who's hypotensive, like we were discussing earlier, you're giving it nebulized. You're not giving it systemically, and so I think that makes a lot of sense. I'd like to see that become more mainstream, because that makes a ton of sense when it comes to trying to relieve some of that RV pressure. It's interesting. I was thinking, like, I'm always talking about ultrasound, and that's because I can use it like in my everyday practice. But what if you didn't have ultrasound? Is there anything like clinical signs and symptoms that would make you think that somebody has a DVT? And you can't do this in an arrest, but have you ever heard of the Homans sign?
Yeah. So yeah, they got to be pretty awake for that. And so you bring their leg up, and then you squeeze their calf at the same time you raise their foot, right?
Yeah,
Dorsiflex, you squeeze the calf and raise the foot. And if they have pain or tenderness or something like that, then it's a positive sign, right?
Yeah, like I don't know. I just think, like, you do it and then you squeeze it, and I would be so worried that you would like, and then all of a sudden,
you just break the whole thing loose, and they just clog off. You know what? That actually did kind of come to think of it. That hurts.
And if they code, yeah, it's a positive sign if you do that and you squeeze real tight, and then their pulse ox drops really low.
Yeah. A 20-point drop.
This moment brought to you by Johnson & Johnson vaccine.
Oh, jeez. But no, I have heard of that, but you can just look for regular stuff too. Like I think in EMS, maybe we just do neglect assessment of the legs and stuff like that a little bit. And so even if they just had bruising or just some swelling or a warm mass or something like that, that would be very worth noting, especially if it's bad. You should maybe be able to find something. So just a little bit of palpation, raising it up, doing that dorsiflexion of the foot and squeezing the calf, just looking for any big red lumps or anything like that, or complaint of pain, pain on palpation, something like that. It's better to do than not to do. And it's not costing you or the patient anything. And it's a very quick exam. The other thing I can think of, not specific to DVT, but maybe just assessing for, I found that pleuritic pain, I found out was more common than I thought it was. And that actually goes along with one of your ultrasound things. those patients can have those subpleural consolidations where you're going in between the ribs and you see like this area of anechoic area. And I was looking into the mechanism of that, and I think it plays into why they get the pleuritic pain, which is when they have that pulmonary embolism, everything distal to that clot. And so if the pulmonary embolism comes up, everything distal to that clot in that artery, it becomes obviously, just like in a heart, it starts to become ischemic, and then it becomes necrotic. It starts to leak. It starts to become edematous. It starts to have cytokine and pro-inflammatory response go to it. And that can happen right at the visceral parietal pleura, where then that area is going to start to become, have atelectasis, and then it's going to start to swell, and it's going to start to become painful for them when it rubs. So I think that's kind of cool. You can see that on ultrasound, and you might be able to pick up on pleuritic pain that's sharp or burning, and then it changes with their respiration. Essentially, that was 66% of all comers had pleuritic pain.
Oh wow!
So I thought that's pretty good. That's not bad.
Yeah,
Especially
I'm on. There's this website called Get the Diagnosis, and so I was looking up like Homan sign, and it's got a 33% sensitivity and then a 79% specificity that the patient has a DVT. But what was interesting is hemoptysis was actually not too low. Like, I didn't realize how often patients who have a pulmonary embolism are actually coughing up blood. But I could see that if you have more of that cardiac output going towards those non-obstructed vessels, that you would start to develop maybe some of the things that would even look like CHF.
Yeah, I can see it too. If maybe even on the same vein as why they get that pleuritic pain, if stuff starts to break down and it's not getting perfused, maybe it becomes a little weak, starts to leak a little bit, or I don't know, it's under stress, maybe it could pop. I don't know. That's an interesting one though. Yeah, I wasn't aware that the hemoptysis was as common as it was. And again, in that same study, the all comers had a 13% hemoptysis rate, but that was all comers. So I'd imagine it's vastly.
So let's put all
to the sicker patients.
So we'll put all this stuff in the show notes, so that way you guys can check it out. We'll put some clips of like McConnell sign and the D sign with the I don't know. Is there another name for it? I think everybody just calls it the D sign, where the septum D's into the
I don't know if you
ventricle.
Can call it the D sign. I think it's just D sign. I think it changes a little bit. I think the D sign is something you get if you wear too tight of pants. I think D sign is more the septum moving.
Awesome, man. Well, I guess we wanted to get this out before we go to New York. We're going to be in New York next week in Albany, right?
Around Albany.
Yeah, we're going to be in Albany, and we're around Albany in that area for the initial assessment conference, and we're going to be doing the Educators Atlas course. It's going to be like a workshop. So if you're out there, we can't wait to see you guys, and we'll probably be doing some more of these now that things are starting to loosen up a little bit. We're both vaccinated, so we'll be coming to a conference near you likely. So if you guys are interested in this type of conversation, check out the FOAMfrat library. It is packed of content, and we have live classes Monday through Friday, 3 times a day, twice on Friday. There's ultrasound content, mechanical ventilation, 24 hours of the critical care stuff that you need a lot of times to renew that endorsement on your license, and you get everything, and it's $160 a year. So if you're interested in that, go check it out. Let us know if you have any questions. And any closing thoughts, Sam?
What's the biggest takeaway for you in researching more of this pulmonary embolism stuff? I'll tell you what mine is. In those massive deteriorating sick patients, the ECGs are more commonly screwed up than I thought they were. I thought it was much more random when they got those changes, but I've got a different appreciation for the processes that do that and where it gets you for a ballpark diagnosis. That's my big takeaway from looking more into this stuff.
Yeah, mine was I want to get better at looking at the legs with my linear probe and trying to diagnose DVTs. And it's something that I have literally at my fingertips that I just don't know how to do that well yet. So I'm going to start looking at how to perform those tests, and then try to get some of the limitations and the safety of it. You know, if I'm pushing down, what's the chances that I'm going to break that loose and it's going to float up? So those are the things that I took away. And I've got a list of stuff I wrote down that I want to start to try to learn so I can get better
Awesome,
with looking at DVTs. Cool. All right, man. I'll hit you up later.